So I think you've heard from the first two speakers how important lifestyle is, as well as family history, which probably impacts how one might think about screening. And so screening for prostate cancer is a very controversial issue. Our next speaker, Dr. Jonathan Wright, is a urologist, a surgeon, who treats prostate cancer, and he has a lot of interest and expertise in screening, and he'll be telling us about that now. Jonathan?
Thank you, Pete. Thank you for giving me a controversial topic to discuss. So, prostate cancer screening does have a lot about it, and certainly it calls on PSA and the role of PSA, and all of us in this room, I'm sure, have seen the tremendous amount in the press about the role of PSA testing and what the government has come down and said whether or not we should use PSA testing. So I'm not going to have an extensive debate over the pros and cons of PSA testing. I'm going to assume for this audience that there is a role for PSA testing. We certainly do believe that there is a role for PSA testing, but we need to use it judiciously and appropriately in our clinics. And so I'm going to talk today, review a few of the issues about PSA screening, discuss ways that we can improve PSA screening, and tell you what new or future screening tests may be coming down the pike. So this has been kind of alluded to. This just shows the top cancers in men and the top cancer deaths in men. And so over here, these are the most common cancers diagnosed every year. Prostate cancer is number one, almost 200,000 diagnoses a year in the United States. It's the second most common cancer death in the United States, with 27,000 men dying of prostate cancer per year. But certainly, as we're moving toward how we can do better screening, we really want to be making sure we are capturing these patients in our screening. There's certainly a significant number of patients that are diagnosed with prostate cancer, low-risk prostate cancer. You're going to hear a lot more about active surveillance later on, who likely don't need to be treated and didn't need to be diagnosed. And as we heard, there is a certain burden of having the diagnosis of cancer applied to you that is difficult to measure. But if you don't need to be diagnosed with prostate cancer, we probably shouldn't be diagnosing you with it and making you carry that burden. This slide shows cancer-specific mortality in the United States over several decades. So these are various decades from the 30s all the way up to early in the 2000s. And these are the rates of death due to different cancers per 100,000 men. And you can see here's prostate cancer. And you can see there was a significant decline in the rate of prostate cancer death. And this coincided about the time that PSA was introduced. Now certainly our treatments have gotten better, and that has made an impact as well. But I think we have little doubt that PSA screening certainly was an important player in this, to diagnose it early when there's a chance for cure. But despite this, the U.S. Preventive Task Force came down and gave it a grade D that we should not use PSA-based screening for prostate cancer. Now, what is PSA? I tell patients this. It's prostate-specific antigen. It is not prostate cancer-specific antigen. And so there are several things that make every prostate makes PSA. So every man is going to have some PSA running around. So there really is no absolute level of PSA below which I can say you don't have prostate cancer. All men are going to have some PSA running around. But we do know that as the PSA goes up, there is an increased probability that you have prostate cancer. But the issues, and these are things that we as clinicians have to deal with, is that there is a concern and there is a reality of overdiagnosis and overtreatment, and our treatments are not benign. What we want to do is be able to identify those two groups. One, those that are least likely to die of prostate cancer, least likely to have morbidity from prostate cancer diagnoses, and not screen them. We want to identify those who are at the highest risk of symptoms or death from prostate cancer, screen those patients, and treat them. So one of the challenges that we had is determining someone's life expectancy. And this is difficult, but there's certainly, as we all know, there's a distinct difference between your chronological age and your biological age. Not every 75-year-old man, for example, is equal. So what this shows is the life expectancy based on how healthy you are for different age groups. Let's start with age 75. The average life expectancy for someone in their average health who's 75 is 10 years. And that's where basically where some of the earlier recommendations said, don't screen men who are 75 or older because they're unlikely to live 10 years and thus they're unlikely to die of prostate cancer even if you found it. But those that are in the healthiest quartile, the top 25 healthiest percent of 75-year-olds are going to live 15 years. And even the healthiest 80-year-old is going to live over 10 years. But the 75-year-old who's not very healthy is unlikely to live 5 years and certainly isn't going to benefit from us doing PSA testing. Well, how do we do with this? This was just published earlier this year. This looks at how much PSA testing we as clinicians do in people who are over the age of 75. And all these different bars show the percentage of men that are getting PSA screening. And it's about 40%. So 40% of men that are over the age of 75 are getting PSA screening. What's worrisome, though, is this 75% is those that have the greatest likelihood of dying in 10 years based on their health. So they're very unlikely to live another 10 years, and yet we're still screening over 30% of those men. We need to do a better job about that. Dr. Stanford alluded to this, is that family history is very important, and we are continuing to unlock some of the clues that we can use to better target PSA, better target screening for patients. She showed these numbers: 40% of prostate cancer due to genetics, father or brother, 2.5-fold increased risk. And if you have 2 relatives with prostate cancer, it's a 5-fold increased risk. That's just basically you're just asking, does your family have prostate cancer or not? That's not getting into the detailed genetics that she's talking about that we hopefully will be able to apply someday for screening populations as well. Race is very important. African Americans develop earlier disease and more aggressive disease. And we need to do a better job of getting these men into our clinics for screening. How can we use PSA better? Well, here are 3 different ways that we can do it better. One is to look at your baseline PSA, and there's some exciting data I'm going to show you that have been coming out about the utility of what your baseline PSA is. What to do when you have a sudden change in your PSA. We see this all the time in clinic, and I'll talk a little bit about that. And then talk a little bit about obesity, too, and how that affects PSAs. So there's a group of men from Sweden. They had over 20,000 men that they collected blood on in the early 80s. And they stored this blood. And then they linked with cancer registry in this area and looked at mortality due to prostate cancer and metastatic prostate cancer. And basically nobody got PSA screening in this area. These curves show the risk of developing metastatic and fatal disease based on what your PSA was when you were in your early 50s. So PSA in your early 50s, no PSA screening, 25 years later, what's the likelihood that man dies of prostate cancer? Well, as it turns out, the median PSA for a man in his early 50s is less than 1. The median PSA for a man in his early 50s is less than 1. These 2 bottom curves have about a 1% probability of developing metastatic disease in 25 years. Those men had a PSA of less than 1. These men had a PSA of greater than 1, and these men had a PSA, when they were 50, of greater than 2.5. Single PSA at age 50, greater than 2.5, 12% risk of dying of prostate cancer in 25 years. So potentially we can use a baseline PSA to then say, if your PSA is 0.4, we don't need to get your PSA every single year. If your PSA is 2.6, we better follow you pretty closely. And we are doing models to try to look at this and what the effects might be of doing these different PSA screening strategies. This is Dr. Rutazioni, Dr. Gore, and Dr. Gulati looking at different protocols. What's the age that you screen? What is the frequency? How many years in between PSAs? And what's your threshold for biopsy? The nuances aren't important. But what we're looking at is our people here are trying to figure out what are the probabilities of finding cancer, overdiagnosis, what's the probabilities of missing cancer, to see if we can, again, use what we have to better screen patients with PSAs. Guy comes into my clinic, he's had a PSA of 1.2, 1.5 for years, all of a sudden it jumps to 4.5, referred for biopsy. I don't biopsy him, I repeat the PSA. A lot of these men I'll repeat, it comes back to 1.5. We just saved that man a biopsy and the risk of biopsy and maybe finding a very small cancer that doesn't need to be found. But if I repeat it and it's still 4.5, then yes, there's been a change. We need to look at that. A very simple way to reduce the number of PSAs, reduce the number of biopsies and the number of diagnoses that we find. Obesity. We heard all about obesity this morning. Obese men have lower PSAs. It's diluted out essentially. Obese men have lower PSAs. It's difficult to feel the prostate in an obese man. It's just difficult to get all the way in there to feel the entire prostate. As a result, we're not very good at finding nodules in obese men. Thus, they can have the disease grow bigger before we can even feel it. They also have larger prostates for some reason. Obese men, bigger prostates. You're trying to find a marble-sized cancer. It's easier to find it in a lime-sized organ than in a grapefruit-sized organ. So it's more difficult to find that little cancer in the obese men. And it appears that obese men have more aggressive prostate cancer. So all of these things we need to apply and think about when we're in the clinic seeing a man who's obese, and 40% of our population is obese. We've also done work here showing that some of the medications that obese men take, or all of us take, statins for high cholesterol, NSAIDs for osteoarthritis, both those medications lower PSA levels. Things we need to think about to do better screening. What's coming new? This is the Prostate Health Index, or the PHI. It is available now. It's a blood test. It uses different forms of PSA. Pro PSA, the free PSA, and the square root of the total PSA, and thankfully it does the math for us. We don't have to actually do any of this, but it is associated with prostate cancer risk. It may be more specific than PSA for detecting it, and what's exciting is it may be better for detecting high-grade prostate cancer. It's available now. We need larger studies. We need better science on it, but this is exciting for something we may be able to use, which is an extrapolation of PSA testing. There are also urine-based tests, the PCA3. We do an aggressive prostate massage. We express things out of the prostate, and then we collect your urine, and then we can look at the mRNA in the urine for different factors. This is PCA3, prostate cancer antigen 3. This is prostate cancer antigen, not the prostate-specific antigen. This is prostate cancer antigen. And this appears to outperform PSA, especially right now we're using in men that have had a negative biopsy, and we're trying to follow them up and figure out should they have a biopsy or not. It doesn't change with your size of your prostate. It doesn't change with prostate inflammation. PSA does change in both of those situations. So this is an exciting test. But it doesn't appear to be associated with aggressiveness of prostate cancer. In this issue, what they give you a score. The higher the score, the greater the probability of having cancer, and something we're using. Tempus-2-erg. Dr. Nelson was intimately involved in the early work with Tempus-2-erg, and we're doing a lot of work here with Tempus-2-erg in the clinics, in the research as well. You'll hear more about it later on. It's a fusion of two pieces of DNA coming together incorrectly, and it's detected in prostate cancer. We can also detect this in the urine of men. And some of the work we've been doing with active surveillance, you'll hear about Dr. Lin talking about later, a recent publication looking at urine levels of this genetic fusion that you see in the urine and outcomes of men of active surveillance. We're trying to see if we can use this in combination with PCA3 to better detect men with prostate cancer. So PSA screening isn't for everyone. We can't go out there and just blanket every single person and PSA test it. We need to make it more focused, and that will help all of us. We need to do a better job as clinicians of assessing how long people are going to live, and that's a tough thing to do. We need better tools to do that, and we need to have frank discussions with our patients about this and say, you're more likely to die of your obesity than you are of any prostate cancer. Get out there and walk 30 minutes this afternoon. Age is not an absolute cutoff for PSA screening. Chronological age is not biological age. We should screen out the PSAs based on what your initial PSA is, continue to look for new tests. And one thing that I do a lot now in clinic is use these smartphone-based calculators, because it allows the patient to have numbers for what's my risk of cancer. This is just one of them that's available. I got a Caucasian male, 65 years old, PSA of 4.5. He's got a family history of prostate cancer. His rectal exam is normal. He's never had a biopsy. His probability of having prostate cancer is 44%. But his probability of having aggressive prostate cancer is less than 10%. So when you have these data, I've had a lot of patients say, I'll see you back in a year with another PSA, or I'll see you back in 6 months, or I want that biopsy. But it's these kind of things, separating out the aggressive from the non-aggressive. And then you'll hear more on active surveillance later on. The non-aggressive, how do we safely follow them? There's a lot of exciting things coming out. There's a lot of work to be done. We're going to continue to do it. And thanks for being here and supporting it as well.
Thank you, Dr. Wright. So I'll put a plug in here. You've heard from the first three talks that there's a lot of complexity here, and I'm sure there'll be a lot of questions. We are planning through the Institute for Prostate Cancer Research to open a prevention clinic where individuals that think they may be at risk can come for advice regarding screening. Family members of those diagnosed with prostate cancer that may think there's a family risk can come for advice and genetic counseling and genetic screening. And those worried about recurrence can come and talk about lifestyle changes and things. So this should be open up in about 1 to 2 months. It'll be over at Roosevelt at the University of Washington. And for those of you interested in that, just let us know. So you've heard a lot about issues related to screening and diagnosing prostate cancer. For many types of cancer, we use imaging. For example, mammography for breast cancer. That's been extraordinarily difficult for prostate cancer. Evan Yu, our next speaker, is a medical oncologist who's been quite interested in innovative approaches to use imaging for monitoring prostate cancer both locally as well as once it's spread. And so he's going to give us a discussion about that. Evan?
Thanks so much, Pete, and appreciate you all being here today. It's obviously a beautiful day outside, so look forward to that walk after we get done with this symposium here. So I will talk about imaging, and I'm going to focus a lot on PET imaging. I think many of you know that standard imaging for prostate cancer are doing CAT scans, which give you kind of an anatomic picture of what things look like. There are also bone scans, which kind of look for cancer in the bones, but they don't really look for cancer in the bones. They look for kind of abnormal uptake in the bones, and anything can look abnormal on a bone scan, arthritis, trauma, fracture, anything like that. So we've started doing some research with PET imaging and PET-CT imaging combined together. And I think the advantage to doing PET imaging is, you see the picture of a patient there in the PET-CT imager, is that it really combines two different types of imaging. It gives you an anatomic picture of what things look like, but it also gives you a molecular picture, a metabolic picture. So the whole idea is you can actually give a quantifiable measure of what's actually happening in the tumor. And there's all different types of radio tracers that we can inject into the patient, and they image different things. So for instance, we can image glucose metabolism, we can image lipid metabolism. We're even able to image certain things like proteins, like the androgen receptor, etc. So there's a lot of different things can be looked at. And also we're able to actually measure exactly how active things are. So that's the point of quantitative, is that you don't just get is it there or is it not there? You get a measurement as to how active is it that's there, a numerical measurement. Another thing that's very important is that if you think about what we use with prostate cancer patients now, I mean, Jonathan just talked nicely about PSA, but PSA is really kind of a broad tumor marker. It's a sum of what's happening in the body. It's kind of all added up together. It doesn't give you any specific information about any anatomic site. And many of you may also know that we have a very robust tumor biopsy program now, where we're not just biopsying tissue in the prostate, but we're actually taking cancer from metastases, tumors that have spread. The challenge with that is that a lot of work's been done, especially in this group here, that shows something called heterogeneity in prostate cancer. And what that means is that we all know that the behavior of one person's prostate cancer may not be exactly like the behavior of the next guy's prostate cancer. But the surprising thing is that even within one person's own body, one side of the cancer in a bone versus another side in another bone may behave very differently and may have genetic characteristics that are very different as well. And so that's an advantage that PET-CT imaging can do, is it can show you potential differences there. So I'm just going to talk about a few different reasons why we would do PET-CT imaging. The first one is just to find the cancer. So one reason is, you have high risk, potentially prostate cancer. You might have had surgery. The PSA might have come back up. And the question is, can we find the cancer where it's at now? Can we still potentially cure it? Can we take it out? Is it in a lymph node somewhere? Can we do radiation or surgery to potentially cure it? Another reason is that, yeah, maybe you have high-risk prostate cancer and you're thinking about undergoing surgery or radiation or some potentially more invasive procedure, and you want to know, is this a worthwhile procedure to undergo? Might we find the cancer somewhere else, like in the bones, where unfortunately it's too late to cure the disease, but we still can use many life-prolonging therapies with hormonal agents. There's a lot of new therapies out there that have recently been FDA approved, but saving the patient from undergoing an unnecessary procedure that might not cure the patient. So I'm just going to cut to the chase with what the best imaging agents are, PET imaging agents we think are for imaging lymph nodes, for imaging bone. I'll start with the lymph nodes. There's been a lot of data recently on choline. We've done some work with acetate as well. And you might ask, what are these agents that we inject into the patient? Well, they're radio-labeled components that are really important for the cell membrane, for the tumor cell membrane. This is important for division of the membrane to basically form the surrounding of the cell and keep the internal contents contained. So this is imaging lipid metabolism with agents like choline or acetate. And the other advantage is that we've been using a cyclotron that we have here, which allows us to generate the radio tracer right on site. We are able to generate C11 radio tracer, which is different than what's standardly used for PET imaging you may have heard of for other cancers with 18F. That's a fluoride-based radio tracer that's excreted via the kidneys, via the bladder. That has challenges. It has a much longer half-life, hangs around a lot longer, and can kind of obscure the pelvic region where we're trying to look at those lymph nodes. This gets broken down into C11 CO2 and gets breathed out via the lungs, and so you're able to really visualize the pelvic region very clearly. And we know that the standard PET radio tracer, which is 18F-FDG, which images glucose metabolism, tends not to be as sensitive or able to pick up prostate cancer as well as some of these other new imaging modalities. So this is the largest series of C11 choline. There's a lot of smaller series. I just wanted to pick the largest one. This was over 2,100 patients, and what they wanted to focus in on are patients that underwent prior surgery, radical prostatectomy, and had biochemical recurrence. That means the PSA started to come up. And in those patients, 358 qualified. They found that 45% of them had a positive PET CT scan. They found cancer in the lymph nodes, in the bed where the prostate lives, and 29% in the bone. And as you can see here, this is basically the prostate bed. Here are lymph nodes. This is bone. And so the whole idea is that this imaging seems to be very sensitive or capable of picking up the cancer, perhaps much better than some of our standard imaging modalities out there. But what they did find is that the mean PSA, the average PSA for the patient that had a positive choline PET scan, was 3.7, and the median, meaning you line 100 guys up in a room, and how high that PSA was for the 50th percentile, right in the middle, was 1.27. What this graphic here shows is that based on what your PSA is, what percentage of those patients had a positive choline PET. So obviously those with lower PSAs had a smaller percentage with positive choline PETs. But once you get up to the 1.5 to 2 range, about half the patients had a positive choline PET scan. What about acetate? Many people have asked about acetate. It's, again, very similar in the fact that it images lipid metabolism. We've done some work here. Much of the work was initiated here early on by Bruce Montgomery and Janet Erie. And this is just a picture of how nice it is. It's able to show a lymph node here, but it's also able to show the prostate there very nicely. Now, it's not the best at delineating what's in the prostate. Is it good at delineating what's BPH, what's high-grade PIN, what's prostate cancer? But you can see the advantage that C11 radio tracers have here in the fact that if you had a patient get 18F, it's a radio tracer that obscures, it's excreted in the kidneys and the bladder, and this whole area would look blacked out there. That's not all cancer, that's just a radio tracer living there. So again, this just shows some of the early work with acetate. So you might ask, what's the verdict? Choline or acetate? There have been more studies with choline, but both really perform in a pretty similar manner. There just hasn't been quite as much work published with acetate, although there's an increasing amount of publications there. Neither is really adequate for the primary tumor, as I mentioned, because the limits of detection are about 5 millimeters, and it's not able to differentiate all the other different pathologies that could occur in the prostate, like chronic inflammation, prostatitis, those sorts of things. But for lymph node staging, we know that choline has very high specificity, ability to pick up the cancer, and acetate performs similarly. So we need to really demonstrate the impact of what it has when we respond to these PET imaging studies. So if you have a positive imaging study and you do surgery to remove those lymph nodes, what happens down the road? Is that intervention something that makes a difference? We don't quite know that. We've certainly had anecdotal cases where we started to respond to this. And there's limited number of treatment response studies. So this is basically looking at bone now. So I'll show you that basically the best imaging modality for bone is probably sodium fluoride PET. These are standard bone scans. This is what we're doing. This is SPECT, which is like a 3D bone scan. And as you can see here on the same patient, you can pick up a lot more cancer with sodium fluoride PET. What's the advantages? This is a small molecule. It's rapidly cleared. You can image very early. It's commercially available and FDA approved. It's more sensitive than standard bone scan imaging or the standard FDG glucose metabolism PET. And when you combine it with CT scan, it increases specificity. So one might ask, if it's so sensitive, how much earlier can you pick up a metastasis with sodium fluoride PET versus a standard bone scan? There haven't been well-done studies looking at that, but I can show you an anecdotal example because we've started using this clinically. This is a patient who you can see here about a year and 3 months or so. It took about a year and 3 months before the cancer was clearly evident on a bone scan in a couple different places there. This patient had very high-risk localized disease and was thinking about undergoing surgery, radical prostatectomy. Here, back about a year and 3 months before that scan showed cancer, we could actually see the tumor in the PET CT in both locations here. So this was able to save the patient from undergoing a curative surgery, which unfortunately would not have been curative because the cancer had already spread. It's just that our standard imaging was not able to pick it up. So I want to talk about the second part of the talk, which is not just finding the cancer, but how about measuring treatment response in the bone? It's very hard to quantify what's happening in the bone when there's cancer in the bone because what you're measuring bone scans is just bone turnover. It's not cancer activity. So what we're able to do basically is use PET imaging to understand the pharmacodynamics, what a drug is actually doing to your tumor and to your body, and measure that, and then help new drug development move forward. So this is a busy slide, but this basically emphasizes the problems that we have with assessing treatment response in prostate cancer that's in the bone. Well, prostate cancer tends to go to the bone, so there aren't soft tissue lesions on a CT scan where we can measure how big or small, how much it's grown, how much it's shrank. PSA is a nice measure, again, potentially for screening and detection, but it's not accepted as a surrogate marker going up or going down. Does that really mean the cancer is getting worse, getting better? We use it, but again, the FDA won't accept it to FDA-approved drugs. And I talked about all the problems with bone scans. It's not perfect. It's not quantitative. It's not measuring tumor activity. Sometimes it can look worse when the tumor is getting better, when you've actually killed the cancer cells. There's healing in the bone, and that actually looks worse on a bone scan. And things don't change quickly. And I've talked about all the problems with FDG PET and imaging glucose metabolism. This is not the most highly proliferative cancer. It doesn't grow the fastest. And for that reason, FDG, or glucose metabolism, is probably not as good. And again, I talked about the issues of obscuring the pelvic region because it's excreted into the bladder. There have been some studies that have been done that have shown that it seems to correlate a little bit with PSA when you're treating patients with chemotherapy. But the nice thing is that recently CMS says that they'll pay for up to 3 FDG PET scans for patients with prostate cancer. But the question is, who are those patients that should be getting that? I think it's probably patients that have, unfortunately, more advanced disease, because we've done some studies here that have looked at comparing FDG PET with acetate PET. And I remember this image is lipid metabolism, this glucose metabolism. This is a patient who you see the bone scan. PSA went down very nicely in response to 3 months of hormonal therapy. Bone scan didn't change. Well, the FDG PET wasn't sensitive enough to pick it up, but the acetate PET changed dramatically there. And so I think the key thing is that this is a hormone-sensitive patient. He just started on hormonal therapies. I think probably FDG PET works better for patients that have more hormonally resistant diseases. I'm just going to run short on time here, so I'm going to get through the last few slides here. I want to show an example of how changes on PET scan might correlate with long-term outcomes. We ran a multi-center cooperative group trial here through Akron, which is the American College of Radiology Imaging Networks, looking at a new drug, dasatinib, which not only potentially has effects in the prostate cancer, but also on bone turnover. And we wanted to see whether changes in response to treatment with dasatinib, as identified by fluoride PET in the bone metastases, might actually correspond with long-term outcomes, meaning the time until the cancer gets worse on therapy. And it did. The interesting thing is it gave us kind of opposite results of what we thought. Instead of the scans looking less intense or better, the patients who did the best were the ones whose scans looked potentially the same or a little bit worse. And this just goes to show how you really got to think about what your imaging rate